my talk is on anti-TB treatment and commonly encountered drug-related complications. Over the next 25 minutes, I will be talking about individual anti-TB drugs, basis of chemotherapy, anti-TB treatment regimens, adverse drug reactions, as well as management of the drug reactions. Basically, in anti-TB treatment, we use the drugs in a hierarchy. We have first-line anti-TB drugs as well as second-line anti-TB drugs. In a short lecture, I will be discussing on first-line anti-TB drugs today. These drugs should be given as short-course chemotherapy. To ensure adequate chemotherapy is being delivered to the patient, we give this as domiciliary treatment rather than institutionalized treatment, and as a short-course chemotherapy under direct observation, so the patient swallows the tablets under the direct observation of a healthcare worker or a trained person. In terms of the first-line anti-TB drugs, currently there are 4 first-line anti-TB drugs. In the past we had 5. However, currently we have 4 anti-TB drugs. We have taken off streptomycin from the first-line group. For each anti-TB drug, we have an abbreviation. H for INH, R for rifampicin, Z for pyrazinamide, E for ethambutol. You all should be familiar with this. What is INH? It is a potent drug which has early bactericidal activity. It kills bacteria. It is a prodrug that converted into its active form metabolite by catalase peroxidase. This active form inhibits biosynthesis of mycolic acid, which is there in the mycobacterial cell wall. The usual adult dose is 5 milligrams per kg. This is adult dose, 5 milligrams per kg per day, up to maximum dose of 300 milligrams. Rifampicin is again potent bactericidal drug which kills bacteria, and also it has sterilizing sterilizing activity. It acts on extracellular semi-dormant bacilli which multiply intermittently, causing relapses. This reversibly inhibits DNA-dependent RNA polymerase, which further inhibits bacterial protein synthesis and transcription. Usual adult dosing is 10 milligrams per kg per day, up to maximum of 600 milligrams per day. What is pyrazinamide? It is bactericidal and sterilizing drug. It acts on acidic environment, so it has sterilizing effect. The mechanism of action is unknown, not fully understood. However, it is assumed that it is converted to its active form, pyrazinoic acid, and possibly inhibit coenzyme A synthesis needed for the mycobacteria. Usual dosing is 25 milligrams per day, maximum dose up to 2 grams per day. Ethambutol is a bacteriostatic drug. It helps preventing emergence of resistance to other drugs. Ethambutol inhibits the enzyme arabinosyl transferases and prevents biosynthesis of the mycobacterial cell wall again. The dosing is 15 milligrams per kg for adults. Little bit about streptomycin, although this is not there in the first line category now. This was previously used, and there are some instances which we can use this. However, currently it's not available. This is again bactericidal drug. Being an aminoglycoside, it binds to the 30th subunit of the ribosome and inhibits the protein synthesis of the mycobacteria. We can use this in certain circumstances. Previously, we used this in TB, meningitis, and other forms of CNS TB, and also when we manage hepatotoxicity during intensive phase, particularly as bridging therapy. This is administered by IM injections, deep IM injections, no oral forms. The dosing is again 50 milligrams per kg. So special note about pregnancy and CKD, which you will be learning in another lecture today. All first-line anti-TB drugs, rifampicin, INH, ethambutol, and pyrazinamide, can be used safely during the pregnancy. Streptomycin is contraindicated. Another important note is using ATT in CKD. In the late stage, particularly in stage 4 and 5, ethambutol and pyrazinamide needs dose adjustment. You can use INH and rifampicin, the normal dose, but ethambutol and pyrazinamide, because it excretes, it has renal excretion, we have to reduce the dose. Uses this 3 times per week. Pyrazinamide 25 milligrams per kg per day 3 times per week. Ethambutol 15 milligrams per kg per day 3 times per week. So what are the TB treatment regimes? We have 2 main treatment regimes with first-line anti-TB drugs. New treatment regime and retreatment regime. Previously we called this, for the new treatment regime was called CAT1, retreatment regime was called CAT2, but now the nomenclature is that not CAT1, CAT2, but new treatment and new regime and the retreatment regime. Each regime is consists of 2 phases, initial intensive phase and continuation phase. During the intensive phase, we give multiple drugs, and during this phase, rapid killing of TB bacilli happens with the multiple drugs. Infectious patients become quickly non-infectious within about 2 weeks, and symptoms improve. Mind you, this is not that the patient converts the sputum, but become non-infectious. Directly observed treatment is essential during the initial phase of the intensive phase for every single dose. This prevents the development of drug resistance because the development of drug resistance is higher in the early phase where the bacterial load is very high. The optimum minimum duration of 2 months should be given for new cases to achieve smear conversion rates above 90% in TB. In the continuation phase, we give fever drugs, but for a longer period. The sterilizing effect of the drugs eliminates the remaining bacilli so that the subsequent relapses will be prevented. During this phase, at least once a week observation, may not be the daily dots, but at least once a week observation is desirable to make sure the patients are maintaining the compliance. The optimum duration is 4 months for new patients and 5 months for retreatment cases. So the treatment regimens we give according to the case definition of the patient. If this is a newly diagnosed patient, either it's pulmonary or extrapulmonary, we treat with new treatment regime, which consists of 2 months of HRZE followed by 4 months of HR. In the patients who have been treated in the past, we go for retreatment regime. Consists of 3 months of HRZE followed by 5 months of HRE. The previously treated categories are patients with relapses, treatment after failures, treatment after loss to follow-up, and other previously treated cases. So I told that the continuation phase we give 4 months for the new cases and 5 months for the retreatment cases. There are certain special circumstances, especially in neurological involvement. Continuation phase should be extended to 10 months, and osteoarticular TB as well. continuation phase is extended to 7 to 10 months. So what is the rationale behind chemotherapy? So there are certain important things to know. In bacteriological perspective, there are two important facts which affects anti-TB treatment. First thing is existence of naturally occurring drug-resistant mutants. So this challenges the anti-TB treatment. So in a TB bacilli population, there are naturally occurring resistant mutants. As an example, in a million of TB bacilli, there is one bacillus which is resistant to INH. Likewise, there is in a million mycobacterial population, one bacteria is resistant to rifampicin. This is not because of the previous exposure to anti-TB or anything, but this is naturally occurring mutants. So we have to consider this fact when we treat the patient with anti-TB drugs. And the other important fact is there are subbacillary populations which have different metabolic rates and they live in different environments. So these two bacteriological factors should be considered when we give anti-TB treatment. This subbacillary population I will explain more in a minute. The pharmacological basis of treatment. So when we treat, we have to achieve maximum peak serum levels of all the drugs at the same time. So we can achieve the maximum bactericidal effect at the same time. So we can kill all the bacteria at the same time. This is achieved by administration of all the drugs at the same time. So more into the existence of subbacillary population. So I told you that there are 4 types depending on the surrounding environment as well as the metabolic rate. So we have 4 groups, A, B, C and D. So this model shows you these 4 subbacillary populations. Group A is extracellular rapidly multiplying bacilli. 4 anti-TB drugs including streptomycin, INH, rifampicin and ethambutol acts on these bacilli. There is another group, Group B, extracellular intermittently multiplying group. They are called semi-dormant. Rifampicin acts on the semi-dormant form. Group C is intracellular semi-dormant form. So they live inside macrophages in an acidic environment. Pyrazinamide is effective on this category. The 4th category is D. They are dormants. None of the first-line anti-TB drugs acts on them. So in a summary, the actions of anti-TB drugs, we have 3 main actions. Early bactericidal activity, killing the bacteria. Sterilizing activity, it eradicates all the bacteria from the intracellular, extracellular, or the semi-dormant forms. And ability to prevent emergence of drug resistance. This is by sterilizing activity. So as I said, to achieve peak serum concentrations of all the drugs at the same time, the WHO has introduced a practical way of giving the medicines with fixed dose combinations we call FDCs. Since 2005 in Sri Lanka we have FDCs. Hope you can read this. So these are the available fixed drug combinations we have in Sri Lanka. FDC2 we have R and H, FDC3 RHE, FDC4 all 4 drugs. So how do we give FDC? So it's fixed drug. So we just give this according to the weight band. So if the patient is less than 35 kilograms, we give 2 tablets. If the patient is 35 to 54 kilograms, we give 3 tablets. Above 55, we treat with 4 tablets per day. Doesn't matter it's intensive phase or continuation phase. It's FDC 4 or FDC 2, 3, whatever. It's the FDC number of tablets are decided upon the weight. Let's move on to the adverse drug reactions. I will be talking again about first-line anti-TB drugs. There are two main types of drug reactions: major side effects and minor side effects. Major side effects, they cause serious health hazard. The ATT should be stopped immediately and the patient should be referred for hospital management. The minor side effects cause only relatively little discomfort. Often patients respond to symptomatic treatment and anti-TB treatment should be continued. Not sure whether you can read this, maybe not very clear. So I'll just go through quickly. These are the common and rare side effects of each and every anti-TB drugs. INH commonly causes nausea, vomiting, peripheral neuropathy, hepatitis, histamine reaction, skin rashes. So rare side effects are psychosis, optic neuritis, SLE-like syndrome, hematological abnormalities. Rifampicin again causes a lot of GI side effects and hepatitis. Reddish discoloration of the body fluids. Rarely it can cause renal failure, shock, thrombocytopenia. I will just explain this with the management because it takes time. Again, pyrazinamide also causes GI side effects mainly and joint pains. Ethambutol, the main problem is optic neuritis, color blindness. This is not given in small children who cannot complain about visual problems. So the management depends on the severity of the symptoms. So in terms of the minor side effects, where we have to continue the drugs, the commonly encountered adverse effects are listed here. Itching of the skin without a rash can be due to rifampicin, INH or pyrazinamide. The treatment is with antihistamines. If the patient is having anorexia, nausea, abdominal pain, again this can be due to rifampicin, INH, pyrazinamide. It's mandatory to exclude hepatitis. You can treat the patient with antiemetics half to 1 hour before giving anti-TB, or give drugs with small meals or as last thing in the night. The joint pains, again due to pyrazinamide, you can treat the patient with analgesics. Burning, numbness or tingling sensation of the hands or feet without evidence of peripheral neuropathy could be due to INH. You can treat the patient with pyridoxine 50 to 75 milligrams per day. However, this should be given 12 hours apart from the anti-TB drugs. Orange or red color discoloration of urine or maybe sweat could be due to rifampicin. It's just reassurance. Histamine reaction occur due to INH. We have to advise the patient when we start ATT not to eat red fish such as tuna, kelawalla and mackerels. When it comes to major side effects, itching of the skin with a rash. It could be due to any anti-TB drug. We have to stop all anti-TB drugs. The deafness and dizziness, those can happen due to streptomycin, which we don't use any longer, and it should be stopped. When a patient gets nausea, vomiting, as I told you earlier, with or without jaundice, this could be due to INH, rifampicin or pyrazinamide. We have to stop anti-TB drugs and perform liver functions. Visual impairment, Due to ethambutol, we have to get ophthalmologist opinion. If optic neuropathy is confirmed, optic neuritis is confirmed, we have to stop ethambutol. In the early stage, the visual impairment is reversible. If the patient gets shock, purpura, acute renal failure, hemolytic anemia, this could be due to rifampicin. You have to stop rifampicin and never try rifampicin again. So little more into ATT-induced hepatitis, because this is one of the commonly encountered side effects which you will see. This is frequently encountered. Incidence appear to be high in this part of the world, and this could be due to hepatotoxic drugs, as you already know. You have to suspect and do liver function if the patient deteriorate appetite, icterus, hepatomegaly, nausea, vomiting. So diagnosis is with the liver functions. If the serum bilirubin level is above normal range or transaminases above 3 times upper limit of normal, you have to stop anti-TB, because this could be due to ATT-induced hepatitis. However, it is important to exclude other causes of hepatitis. So this is a retrospective diagnosis. So how do you manage? Basically, if you can stop anti-TB drugs and keep the patient off anti-TB drugs, stop all anti-TB drugs, wait until serum bilirubin and liver functions returns to normal. Once they are normal, you can restart one by one in the order of start first with INH, and then rifampicin, then pyrazinamide. Each drug starting with a lower dose, gradually increase to the full dose in 3 to 4 days. You have to repeat liver functions once a weekly or less than that, to make sure that patient is not getting deterioration of the liver functions with the introduction of each anti-TB drug. To cover we call this desensitization. To cover this period, you can use ethambutol and, if available, streptomycin while you introduce the anti-TB drugs. This is to make sure that you are not giving exposing the patient to a single drug at a point. So if the patient is having severe disease where you can't stop all anti-TB drugs, so what you are going to do? So in such instances, patients should be treated with at least 2 least hepatotoxic drugs. So you can use streptomycin and ethambutol if the patient is not allergic to them, until the liver functions come back to normal. However, this is a weak combination, streptomycin and ethambutol, which may not be adequate to your severely ill patient. In such instances, you can, if the patient's bilirubin is high but AST/ALT is normal, you can combine INH to the regime. If the patient's bilirubin is also high with AST/ALT, in that case you can't give INH, so you can combine with levofloxacin. It's important to get respiratory physician's opinion when you do this. So usually hepatitis occurs during intensive phase. Most patients, we can restart standard ATT regimen after desensitization. During the reintroduction of the individual drugs, if any drug found to cause recurrence of hepatitis, it should be withdrawn from the regime. If standard regime cannot be reinstituted, modified treatment regimes should be arranged. So the last slide, ATT-induced skin sensitivity. Here you have to, so this is patient is having itching with a rash. So you have to exclude other causes for skin rashes. All anti-TB drugs should be withdrawn because all can cause skin sensitivity. Once the rash resolves, you have to reintroduce one by one with the sequence of start with INH, then rifampicin, followed by pyrazinamide, ethambutol, the last, if you need, streptomycin. each drug should be increased over 3 to 4 days. Because all the anti-TB drugs causes skin sensitivity, there is no chance to give alternative regimen until the rash subsides. Any drug which is found to cause recurrence of skin rash should be withdrawn, same as the ATT-induced hepatitis. So these are my references. You can get more information from the National TB Guideline. 2021 update is there online. This is the end of my presentation. Thank you for your attention and time.